We are really thrilled that Dr. Fauci will now deliver this year's American Osler Society John P. McGovern Lecture. Dr. Fauci was elected an honorary member of our society last year in recognition of his extraordinary contributions and career in medicine, public health, and scientific leadership, which embodies qualities championed by Sir William Osler: compassion, scholarship, hard work, and a lifelong commitment to the service of humanity. While Dr. Fauci is now mostly known for the significant role he played during the COVID-19 pandemic as a renowned infectious disease specialist, public health expert, and former director of National Institute of Allergy and Infectious Diseases, he was at the forefront of the fight against AIDS when it emerged in the 1980s as a deadly new disease claiming thousands of lives, mostly of individuals belonging to the gay and other marginalized communities. Dr. Fauci's ability to combine rigorous scientific insight with clear, compassionate communication throughout the AIDS epidemic served as a beacon of trust during a time of great uncertainty. He powerfully demonstrated the relevance of humanism in medicine at the highest levels of biomedical research and public service. His lecture today will shine light on the AIDS epidemic's impact on society and healthcare, describing the challenges that were faced by virologists, researchers, patients, healthcare providers, and policymakers. He will unravel the complexities that eventually led to groundbreaking treatments, emphasizing the importance that advocacy and education played in combating the stigma associated with AIDS. And his lecture will encourage us to reflect on the lessons learned from one of the most significant health crises of our time, and remind us that history is not merely a collection of dates and events, but also a living narrative that informs our present and shapes our future. So I now turn the virtual podium over to Dr. Fauci.
All right, thank you so much. First of all, I want to thank you so much for giving me the opportunity to present the 2026 McGovern Lecture to the Society. As you can see on this first slide, and as was just mentioned in the introduction, that I'm going to be speaking to you about my experience over a 45-year, as I refer to it, as a personal journey in HIV/AIDS science and policy. But before I do, I want to just say how grateful I am to have the opportunity to help you to honor Dr. McGovern, who I understand from his dedication to patient-centered care, which was inspired by the training from Sir William Osler. It's a great honor to be giving this lecture in the honor of Dr. McGovern. So let me proceed and tell you how I'm going to divide the lecture. I've divided it into 4 time brackets, and the reason for my doing that will become apparent to you in a moment. The first bracket, from 1966 through 1981, were the years in my professional career that antedated my involvement in HIV/AIDS. And I thought it would be good for context to at least give you some idea of where I came from in that very early arc of my career that put me right in the eye of the storm of HIV, which in fact has had me involved, as the title slide showed, for the past 45 years. So let's start off with 1966 to 1981. As I'm sure many of you in the audience had similar experience, I went to medical school at Cornell University Medical College, and then I spent a year and a couple of years of internship and residency at the New York Hospital Cornell Medical Center, which is now Weill Cornell, or Presbyterian Cornell Hospital. After my residency training, I went to the NIH in Bethesda, Maryland for a 3-year fellowship in a combination of fellowship of infectious diseases and clinical immunology. And as I tell my students and trainees about the non-linear aspect of one's career, I had the full intention of returning to the New York Hospital and practicing medicine in the teaching hospital of Cornell, New York Hospital, as my career trajectory. But something changed. When I went to the NIH, I became enamored of the concept of also making research part of my career. And this is the picture of our fellowship group in my first year as a clinical research fellow at the NIAID. And I circled that red circle was my mentor, Dr. Shelley Wolf, who had a great influence on my career in convincing me to stay in the realm of a combination of clinical medicine plus basic and clinical research, rather than just going back to New York Hospital into practice the way I intended. And while at the NIH, I did a lot of research on immune-mediated diseases, particularly Wegener's granulomatosis, now known as granulomatosis with polyangiitis. And I had a prematurely successful career in developing some rather important clinical protocols to put this otherwise fatal disease into remission to the tune of about 93%. So I became much more enamored of clinical research. I went back to the New York Hospital in 1971 to be chief medical resident in the Department of Medicine. And there I am. You might not recognize me on the lower right part of the screen, sitting down there next to my chairman of medicine, Alec Bairn. I then went back to the NIH in 1972, full-time as a senior clinical investigator. And for the next several years, from 1972 to 1981, I was involved in research on immune-mediated disease, even though by that time I was board certified, not only in internal medicine, but in infectious diseases and in clinical immunology and allergy. I show this slide because it really is an extremely important slide that reflects the attitude at the time about the role of infectious diseases. Robert Petersdorf, some of you in the audience may not have heard of him, but he was an icon in infectious diseases for decades in the 70s and 80s. And Bob Petersdorf wrote an opinion piece in the New England Journal of Medicine in September of 1978, when he was referring to the number of infectious disease fellowship applications that were submitted that year. And he wrote, and these are his exact words, "Even with my great personal loyalties to infectious diseases, I cannot conceive of a need for 309 more infectious disease experts unless they spent their time culturing each other." What he was referring to was the attitude at the time that with vaccinations and antibiotics, and then the beginning of the era of antivirals, that there really was not much need for specialization in infectious diseases. Little did he know what was to happen over the coming 3 years, which gets me to the second bracket of time from 1981 to 1984. This is a morbidity and mortality weekly report from June of 1981. Now, to get back to the context of what I'm talking about, by this time, I had been a senior investigator at the NIH from 1972 to 1981, with a rather, I might say, successful career in delineating and developing treatment protocols, mostly for autoimmune, immune-mediated diseases. Again, despite the fact that my clinical subspecialty was infectious diseases. So this MMWR landed on my desk in my office in Building 10, the clinical center at the NIH campus. And it was a report of 5 young men, curiously, all gay men, who presented in Los Angeles with biopsy-confirmed pneumocystis pneumonia. 2 of the patients died. I have to say in all transparency that when I read that in my office, I blew it off as a strange one-off outlier Perhaps these men took some drug which they were using for sexual enhancement, poppers they called it, that somehow compromised their immune system. But 1 month later came an MMWR that I might say without hyperbole changed my professional life and my entire life. And it was the MMWR which now reported 26, not only curiously, but amazingly, 26 gay men who were previously well from New York City, Los Angeles, and San Francisco, who now presented not only with pneumocystis pneumonia, but with a whole variety of opportunistic infections only seen in people with compromised immune systems, together with Kaposi sarcoma, again, a neoplasm that we know is associated with immune compromise. I made a decision literally that month that I was going to do something against the advice of my mentors to put aside the successful career direction that I had been doing for the previous 9 years from when I came back from my chief residency in 1972, and then studying full time this mysterious disease that didn't have a name and did not yet and would not have an etiologic agent for the next couple of years. And that's what I did. And here's some examples of what went on back in that era more than 40 years ago. The names that were given to this disease: gay-related immunodeficiency, gay cancer, gay plague, and a variety of other now seemingly quite inappropriate names. It wasn't until September of 1982 that I and a number of my colleagues from the CDC and the Department of Health and Human Services sat down in a conference room downtown Washington and decided that the most appropriate thing to be would be to call this a syndrome, and the acquired immunodeficiency syndrome. Remember, it's 1982 and HIV had not yet been identified, but at least now we had a case definition of what we were calling the acquired immunodeficiency, or AIDS. And over the ensuing months, from July of 1982 to January of 1983, it became very clear to us that this was not a disease that was exclusively confined to young gay men. We started seeing among heterosexual Haitians who had migrated mostly to New York and to Florida. We saw it in patients with hemophilia who were transfused with blood products, people who received transfusions for blood loss and anemia. And then we started seeing the infection in infants born of women who were actually in relationships with people who ultimately had AIDS. And then finally, clearly, female sexual partners of people with this new syndrome, again, the etiology of which had not yet been determined. Another interesting thing is that you see from this slide, a fellow from my group at NIAID, Tom Quinn, together with Peter Piot, who was at the University of Antwerp at the time, had a project in Zaire, now called the Democratic Republic of the Congo. They were seeing people in Southern Africa, particularly in Zaire, with syndromes that appeared to be identical to what we were seeing in the United States. But interestingly enough, they couldn't convince people that this was AIDS because it was inappropriately thought that AIDS was confined to gay men. And what our African colleagues were seeing was a male to female ratio of 1:1. So it was clearly a heterosexually transmitted disease. As we will learn over the years, it's predominantly a heterosexually transmitted disease. and it is predominantly in low and middle income countries, and 67% of all cases are in Southern Africa. We did not know that at the time. We did not know the extent of the global penetrance of HIV. And while we were doing this, this is a picture of me and my close colleague, Cliff Lane. Since, as you can see, it's still 1983, what we did was to try and delineate the pathogenic mechanisms of this disease without an etiologic agent. And we determined there was aberrant immune activation, that there was selective diminution of a certain subset of T cells, but again, it still remained a mystery until the summer of 1983, when Luc Montagnier and Barré-Sinoussi from the Pasteur Institute in Paris isolated and identified a new virus in the lymph node of one of their gay patients in Paris. It wasn't definitively shown epidemiologically to be the etiologic agent until 1984, when Bob Gallo and his colleagues a year later linked the identification of the virus itself with the epidemiological picture of the sexual transmission among, in this case, mostly gay men. And for their groundbreaking discovery, both Françoise Barré-Sinoussi and Luc Montagnier received the Nobel Prize in Physiology or Medicine in 2008. In 1984, because I was very concerned that we were paying little attention to infectious diseases in general, a la the New England Journal of Medicine paper that I showed you a few slides ago from my friend and colleague Bob Petersdorf, and because of the lack of support and interest in what I perceived was a growing pandemic, even though we didn't realize the pandemic nature of this disease yet, I decided with some reluctance to take on the position, in addition to my research and clinical work, as the director of the National Institute of Allergy and Infectious Diseases, a position I held for almost 40 years until I stepped down at the end of 2022 and early 2023. So let's get on now to the next bracket of years of this journey of 45 years of HIV. So we'll go from 1984 to 1996. I refer to that, and I wrote a memoir about this a couple of years ago called On Call, which I described, among a number of other things, the early years, and I talk about this a lot to the fellows, interns, and medical students that I deal with now, how unusual and stressful it was to be taking care of mostly young gay men who were desperately ill with a disease that we didn't yet know what the etiologic agent was. And when we finally found the etiologic agent in 1983 and 1984, there was very little we could do about it because, as you'll see in a few minutes, we didn't have any antiviral drugs until several years later. So I referred in my writings to this as the dark days of my professional life, because unlike what I was doing from 1972 to 1981, in where patients who had diseases in which they thought they were going to die from, our protocols essentially put them in 93 to 95% remission, whereas here, essentially, all of our patients died because by the time they presented to us, they were already clinically ill, and they probably had been infected for several years. In fact, the median time from infection to clinically identifiable AIDS disease was anywhere from 8 to 10 years. So those were very stressful times. As shown by some of the early writings here in the New England Journal of Medicine, the probability of death in 1 year was at least 50% and close to 100% at 5 years. The early examples of things that we tried, any of a number of drugs that, as you see from this slide, none of which were shown to have any important effect on the virus itself. But we were desperate, looking for any potential therapeutic intervention. And it wasn't until 1987, when Bob Yarchuan, Sam Broda, and Mitch Mitsuya at the National Cancer Institute developed an assay for growing the virus and measuring the effect of therapeutic interventions. And in collaboration with Burroughs Wellcome Pharmaceutical Company, they screened a whole bunch of drugs that had already been developed for cancer, but that had failed as cancer drugs. And one of those was AZT. And that drug showed in a clinical trial, because in vitro it was shown to suppress the virus, the first and only placebo-controlled trial of a drug that clearly had some effect on the virus. And this is a classical paper from the New England Journal of 1987. And as you can see from the left side of the bar graph, that those who received placebo, 19 of them died, whereas those who received AZT, only one of them died. This drug was very rapidly approved by the FDA. However, as the research identified vulnerable targets in the HIV replication cycle, a number of other drugs, now AZT, as you know, is a reverse transcriptase inhibitor. But as other vulnerable targets were identified, such as protease and integrase and fusion mechanisms, a number of other drugs from 1987 onward began to be developed and tested, mostly by support from my institute, NIAID, in close collaboration with a number of pharmaceutical companies. And this slide really shows you the gradual progression, improvement in the use of antiretroviral drugs. So let me very quickly walk through it with you. As you can see, in 1987, with AZT monotherapy, we are plotting time on the x-axis and level of virus on the y-axis. AZT dropped the level of virus nowhere down low enough to be below detectable level, and the effect was transient, because over time, as you might expect, with a single drug that's an RNA virus, that you will get mutations that will evade the therapeutic effect of the drug. But as the years went by, we developed other drugs, particularly lamivudine, which was part of a true two-drug therapy, which in the early to mid 1990s dropped down the level of virus much lower, but still not yet undetectable. And again, we still saw the development of resistance, which had the effect of the drug, as you can see the red circles going up and up regarding viral load. But it wasn't until 1996, which was the banner year of the antiviral approach towards HIV, when three-drug combination that was anchored in a new drug called the protease inhibitor for the first time dropped the level of virus clearly below detectable level, and importantly, kept it there. And the reason is when you suppress a virus to below its replication capability, it becomes very difficult, if not impossible, for that virus to mutate. So drug-resistant mutations became very rare, unlike what we saw with one drug and two drugs. So 1996 was the banner year for antiviral therapy. Now let's go to the next bracket of years, 1996 to the present time. These are the papers that emanated out of that important meeting that took place in Canada, in Vancouver, in which the studies were presented, showing for the first time antiretroviral drugs, which did what I just told you a moment ago. And in fact, the results were nothing short of spectacular. This was the AIDS deaths in the United States. From the time, as you can see, 1996, the number of deaths continued to go up and up until the introduction of effective antiviral therapy. They took a precipitous drop over the next couple of years. And this is a typical picture of a person. This was a patient. We saw this all over in New York, San Francisco, LA, and all the big cities. But this was a slide that was lent to me by my dear friend, the late Paul Farmer, who showed one of his own patients in Haiti who was really essentially on death's doorstep, shown on the left panel, who 3 months after the initiation of antiviral therapy had what we were seeing here in the United States, essentially a miraculous recovery, which, as you know, was referred to colloquially at the time as the Lazarus effect of antiviral drugs. Fast forward to today, there are now more than 40 FDA-approved antivirals, including, importantly, 14 formulations of a single tablet containing 2 to 3 drugs, which when given once per day, consistently maintains the level of virus below detectable level. Now, the FDA just literally last month approved a drug which is a combination of doravirine and islatravir, which is the first complete once-day 2-drug therapy that doesn't have an integrase inhibitor, because the integrase inhibitors were really the fundamental basis of the great responses we were seeing. Now, over those years, from 1996 to 2026, i.e. the present time, a couple of very important observations were made regarding the extraordinary efficiency, and on this slide, I refer to as transformational HIV interventions. We found out in a number of studies that if you treated a person and got the viral load consistently below detectable level, it became virtually impossible, and we very rarely say that in clinical medicine, but it became virtually impossible to transmit that virus to your sexual partner. That led to a terminology which is referred to as U equals U, or undetectable equals untransmissible. We also found out that if you give 1 pill a day to a person who is at risk but not infected of a 2-drug combination pill called Truvada, you have a 99% efficacy in preventing the acquisition of HIV infection, which is most extraordinary. So if you combine U equals U with 99% efficacy of pre-exposure prophylaxis, you know that we have the tools already to end the pandemic if we can only implement it. These are the results. I showed you that picture of me on rounds in the 1980s, in which my patients had a life expectancy of 1 at the most 2 years from diagnosis, because we did have the capability of at least treating most of their opportunistic infections. But if you fast forward to today, if a 20-year-old, 21, 25-year-old comes into our clinics with newly acquired HIV infection before they became clinically ill, and we put them on the combination regimens that I showed you on the prior slides, you can look that person in the eye and tell them it is likely, all other things being equal, that they would live an additional 56 years, which would make their life expectancy only about 1 to 3 years less than the life expectancy of someone who does not have this illness. Now, I want to just spend a few minutes and a few slides on telling you about the critical role of AIDS activism in the story and the saga of HIV/AIDS. Back in the early years, understandably, the mostly young gay population was very dissatisfied with the amount of effort the government was put in. And during Ronald Reagan's presidency, they had a point, because he was inaugurated in January of 1981. And a few months later, with the first cases of AIDS, as I showed you on a prior slide, in the summer of 1981. But he did not mention the name AIDS until the second year of his second term, which really means he missed the opportunity of using the bully pulpit of the presidency to call attention to this emerging pandemic, not only in the United States, but as we found out, globally. In addition, they wanted a say in the design of clinical trials to be more accessible to them. This is someone who at first was a nemesis of mine, but at the time he died became one of my close and dear friends. The iconic activist Larry Kramer, who was trying to get the attention of federal officials, including me, being a member of the NIH, which is part of the executive branch, wrote an essay on the front page of the magazine section of the San Francisco Examiner in 1988. I called you murderers, an open letter to an incompetent idiot, Dr. Anthony Fauci. Well, if he was trying to gain my attention, he certainly gained my attention. But it was really important, because what I did at that time, in the mid to late 80s, I made a decision that even though the activists were being very disruptive, iconoclastic, theatrical to get the attention of the scientific and regulatory community, I extended myself to them. And this is a picture of me in the Gay and Lesbian Community Center in the middle of Greenwich Village, sitting down with a large number of rather angry, frightened, and many of them ill young gay activists, listening to their concerns. And this outreach, I think, was one of the most important and best things that I have ever done in my professional career, because what we were seeing was that they were not having what we call compassionate accessibility to drugs in clinical trials. So look at the date on this New York Times. It was about a year and a half to 2 years after the only single drug was approved. So they wanted to have what's called parallel track, or the ability to have access to drugs. And I did something that was, I think, noteworthy in my long career, is that against the advice of the FDA, I sided with the activists to give them wider access to drugs while they were also in clinical trial. And we refer to this as parallel track approach to clinical trials, which in essence was the beginning and the birth of compassionate usage. And it worked really very well. Now, I put the circle around this young man on the left-hand part. He was the most articulate of the gay activists. And some of the things that he did to gain the attention was a master class in disruptive advocacy. So here is a storming the NIH. This is the campus of the NIH where I spent 54 and a half years of my professional life. Again, saying we needed to do more research and we needed to be more flexible on clinical trials. So here is Peter Staley climbing onto a window and the overhang of Building 31 on the NIH campus, getting arrested in order to be visible in his protest. A documentary, which was actually nominated for an Academy Award, told the story of these brave activists. And here's a picture of Peter. It actually is at the time that he actually got arrested off this roof, and he's handcuffed behind his back. Is called How to Survive a Plague. To show you how things evolve, our relationship and my own personal relationship with the gay community evolved in a collaborative and productive way, to the point that more than 25 or 30 years later, there's Peter, now with a lot of gray hairs, and me at the Harvard Kennedy School Institute of Politics, reminiscing in a fireside chat about the role of productive activism when you're dealing with a catastrophic disease such as HIV. So I thought I would just tell you that little story because it is really an important part of the history of HIV/AIDS. So let's get down to some of the relationship between policy and politics. When George H.W. Bush was vice president and decided he wanted to run for president, it became very clear to him that he needed to learn a little bit more and get a bit more understanding of this disease, which was devastating mostly the gay population in the United States. So he actually reached out to me and asked if he could visit our group who was seeing these persons at the NIH in the clinical center. So when he became president, I invited him, and here is the solarium of my ward at the clinical center. And the people sitting around in this circular group are a group of my persons with HIV. Now, unfortunately, since this is 1988, most of the AIDS patients there who did not yet have access to effective drug have since expired. The president was very interested in this and listened very carefully. This was the first real understanding on the part of the highest levels of government of the importance of major investments in this. And here you see me sitting next to President George H.W. Bush. I want to point out one other thing in this slide that would have otherwise gone unnoticed, that sitting off in the corner in this solarium was someone you might recognize, the president's son, George W. Bush, who at the time was a staffer at the White House, well before he became the governor of Texas and well before he was the owner of the Texas Rangers. The reason I show you this part of the slide is because years later, several years later, George W. Bush would play a major role in how we address HIV globally. And I'll get to that in a moment. But getting back to his father, George H.W. Bush, you can see when he became president that the resources of research for HIV in the United States dramatically increased because of a realization, and this was not only the president, but it was a bipartisan support from both the Democrats and the Republicans in Congress. Now, as the story starts evolving, there was a study, very important, that showed that if you treated pregnant women with AZT in the second or third trimester and gave the newborns AZT for 6 weeks following birth, that regimen reduced mother-to-child transmission by about 2/3 compared to placebo. We were thinking of what we can do in the developing world, but this was clearly too expensive to do. So conventional wisdom was that the regimen of AZT is too expensive and not feasible for sub-Saharan Africa. However, a few years later, a drug called nevirapine was shown, very interestingly, that if you gave a single dose to the mother during labor and a single dose to the baby following birth, you can have a dramatic diminution of the incidence of mother-to-child transmission. And when that study came out, it became clear, together with a number of other things, that maybe we could do something in the developing world which had no access to therapy at all. So the newspapers and the media was very excited about that. So for $4 for the cost of this 2-dose regimen, you could save an infant from getting HIV. Why was this important? Because in Southern Africa, when you went to antenatal clinics, 40 to 50% of the pregnant women were infected with HIV. Seems like an astounding number, but it is a true number, well documented multiple times. So then, as you see, that was 1999, 1998. As we get to the year 2000, it became clear that there was an incredible disparity in access to life-saving drugs. By this time, 4 years after the transformational understanding of triple combination and the amazingly dramatic results that we were seeing in the developed world, still in sub-Saharan Africa, which epidemiological studies are showing us has 67% of all the people with HIV are in sub-Saharan Africa. And yet they had zero access to drugs that was saving the lives of people in the developed world. So I took a trip, one of my several trips to Africa, to Uganda in April of 2001, and met with a number of my African colleagues and collaborators who convinced me that if we gave them the resources to have drugs, they could have as dramatic results as we were having here in the United States. And I say that because many people in the United States, even those who testified before Congress, said that you'd never be able to get antiviral drugs to Africa. They wouldn't know how to take their drugs. They wouldn't accept it. And it might not even work in them, which, when you think about that, that is slightly, if not terribly racist to say that. But that was the prevalent attitude at the time. Now, why do I show you this slide? Because the date of this is 2001 April. And what happened in September of 2001? And that was the attacks, the terrible attacks of the terrorists in New York and in the Pentagon, but also a couple of months or a month later, the anthrax attacks by mail. Some of you may remember. So when you juxtapose these two, we thought, the US government, that the anthrax attack was another part and another chapter in Al Qaeda's attack on us. As it turned out, as you all know, it was a homegrown person from Fort Detrick in Maryland who actually sent these letters out. But we thought we were in for another bioterror attack. So President Bush decided to put a considerable amount of money into the development of research to counter bioterror. And here he is making that announcement with me, and the head of the CDC at the time was Julie Gerberding, and you see other officials there. He proposed a record $27 billion for the NIH, $1.5 billion of which would be aimed at bioterrorism. However, again, one of the things that I'm feel good about and I'm proud about was my ability to convince the president and the Congress that that money should not only go for bioterrorism, but for all emerging infectious diseases. In fact, in a very notable time, I developed this rather, I would say, strong, trusting relationship with President George W. Bush. And when he was getting ready to give a speech in Pittsburgh about monitoring for bioterror attacks, he invited me to join him on Air Force One and go to Pittsburgh with him. And on the plane, on the way back from Pittsburgh to Andrews Air Force Base, he asked me what scared me the most about microbial terror. I said, Mr. President, I worry more about the natural occurrence, particularly of things like HIV, which is a current plague. He had already developed an interest in that. So look at the date. It's February 5th, 2002. Okay. Now I'm going to talk about how all of what I've told you over the last few slides leads to what I refer to as the origin of PEPFAR. A couple of months later, remember, I want to go back here. This is February 2002. In April of 2002, the president called me to the White House with his staff, and I wrote this down when I went back home because it was obviously an important meeting in my life. He said, we as a rich nation have a moral obligation to help those who do not have access to HIV treatment and care because they lack the resources. So he told me to go back to Africa and see if we, in fact, could put together a program that's transformational and accountable. So I went back to Africa and visited these countries, and I came to the conclusion by what they were doing in Africa that they, in fact, could handle in a very positive way an HIV prevention and treatment program. So I came back to the United States and I said, one easy thing we could do is to give them $500 million, $500 million, in order to get them to give nevirapine, one dose to the mother, one dose to the baby, and we could block significantly mother-to-child transmission. So I presented this to the president in the Roosevelt Room, and he was very impressed with that possibility of saving the lives of children. So he said that he would go along and approved this mother-to-child prevention initiative. But to my great surprise, that after he did that, he called his chief of staff at the time, his deputy chief of staff, Josh Bolton, and me back into the Oval Office and said that the mother-to-child transmission initiative is a great start, but we need to do something on a much broader scope, something that's truly transformational. And he told me, work with Josh, who's the guy in the lower left, and put something together for us. And it needs to be, as I said, transforming and accountable. So that, in fact, is what we did. Oops, And from June of 2002 to December of 2002, I worked with the White House staff on putting together what I hoped the president would accept would be a transformational and accountable program. So I made a proposal that we should put together a program which the president, to his great credit, because it wouldn't have happened without him, announced on January 28th, 2003, what we decided to call the President's Emergency Plan for AIDS Relief, or PEPFAR. And my proposal, which he accepted, thank goodness, was for $15 billion over 5 years, aimed at preventing 7 million new infections, treating 2 million people who are already infected, and caring for 10 million people, including vulnerable children and AIDS orphans. Fast forward 20 plus years, and what started as 15 countries for $15 billion has now expanded to more than 50 countries for a total of $130 billion. And the results are really nothing short of spectacular, because at the end of December of 2024, if you calculate the impact, more than 26 million lives were saved, more than 7.8 million babies who otherwise would have been infected were born HIV-free to mothers with HIV, and close to 3 million people were enrolled on PrEP, which means that they have a 99% chance of not getting infected. The reason I show you the results is this can really tell you what presidential leadership can do, because this turns out to be the most transforming public health program for a single disease in history. That's the good news. The bad news is that one of the major implementers of the PEPFAR program is the USAID. And as we all know, unfortunately and sadly, and I think tragically, that program has now been dismantled. As you can see, this person scraping the name of the agency for United States Agency of International Development off the building, which I think is very ill-advised. And in fact, just last month, the New York Times had an article showing that new data is showing worrying declines in testing and treatment for HIV. If you compare 2024 with 2025 on the right-hand part of the slide, look at the diminution, not only in HIV testing, on the initiation of PrEP, the number of people who are receiving therapy, and the number of children that are receiving therapy. So as I'm getting to the close of this, HIV does remain a global pandemic, even though it's off the radar screens of many people. As I mentioned in the first slide, we're now close to the 45th anniversary of first recognizing in the summer of 2001. So look at the extent of this. There are 40.8 million people globally living with HIV. And even with the interventions that we have today, with treatment and PrEP, 1.3 million people newly acquired HIV in the last reportable year, which was reported in July of 2025. And there were 630,000 deaths due to AIDS and 44 million cumulative AIDS deaths over the entire time. It continues to disproportionately impact the global South because of the 40 plus million people living with HIV. As I mentioned a bit earlier, more than 90% are in the developing world, and over 65% are in sub-Saharan Africa. In the United States, there really is still a significant problem, which we tend to gloss over. In 2023, we had 1.2 million people living with HIV, and even though we have readily available testing anywhere, nonetheless, 13% of the infected people are unaware that they're infected. Sorrowfully, as I say, and tragically, there were 39,000 new infections of HIV in the United States, with close to 5,000 deaths. Yet we have highly effective pre-exposure prophylaxis. And since the start of the pandemic, more than 700,000 people in the United States have died of HIV. So we have what I refer to as a global HIV treatment gap. And here is a rather simple graph showing you that. Of the 40.8 million people living with HIV, gladly, 31.6 are on therapy, but 9.2 million people are not receiving therapy. A terrible disparity. We want to augment the ART medicine cabinet with long-acting drugs, which makes it much easier for a person to essentially tolerate the daily medication burden. And as some of you may know, the FDA approved the first extended release injectable drug called Cabenuva, which is a long-acting cabotegravir and rilpivirine, which can be given every 2 months. So instead of taking a pill every day for treatment, you can take an injection, IM, every 2 months. And also, new antivirals in the pipeline can be part of a twice yearly treatment. Now think of that. You have a disease now where you can come in for an injection, likely once every 6 months, and keep the level of virus to below detectable. There's also a global HIV prevention gap, similar to the treatment gap. I told you just a moment ago that you have a pill that if you give it one a day is 99% effective in preventing sexual HIV transmission. However, it remains underutilized. The need for pre-exposure prophylaxis for HIV is around 2.2 million people would benefit for it. Yet, if you look at who's receiving it, less than 30% of those who need it, only about 591,000. Another thing, if you look at the PrEP coverage, the global PrEP needs 1.79 is what is happening. The need is measured in multiples of that, tens of millions. Again, a disparity in the need versus the implementation. How are we trying to remedy that? In addition to treatment getting long-acting drugs, we now have long-acting long-acting drugs for prevention. And one of the most exciting advances in HIV over the last several years is a drug which is a capsid inhibitor called lenacapavir, which in a number of trials had extraordinary efficacy. 2 trials, one called Purpose 1, published in the New England Journal, showed 100% efficacy. I mean, whenever do you get 100% efficacy in a clinical trial among women and adolescent girls in over 5,000 people? And a year later, a 96% efficacy among men and gender diverse people who were given lenacapavir, a single injection, twice a year, every 6 months, which is going to remarkably uncomplicate the daily need for prevention for those who are uninfected. Now, again, getting back to points that I want to make that is relevant to today is that if you look at the target for lenacapavir, they're going to give it to about 3 million people. It's been approved. Well, actually, 20 million people need to be antiviral-based prevention by 2030. So we're not on mark for something that could actually end the pandemic. I'm telling you these things because, we were on a real track of momentum against HIV, which has actually over the last year to year and a half been slowed down. I'm not going to talk about a vaccine and a cure, only tell you that those are formidable challenges that remain in HIV science. But as I'm alluding to, we could very likely end the epidemic even without a vaccine. So, in closing, if you look at the past, present, and future history of HIV/AIDS, we're not going to eradicate this infection. We've only eradicated one human infection in history, and that's smallpox. And we did that with an extraordinary vaccination campaign. I don't think we're going to eliminate it because it's such a pervasive disease. The approach was really going to be, and I would consider this fulfilling the definition of ending the HIV/AIDS pandemic as we know it, and that is to control it at the lowest possible level. And how do you do that? It's by implementation of the scientific advances that we have. Now, I know this sounds pie in the sky because at the level in the trenches of implementing it would be difficult. But since treatment, bringing the level of virus to below detectable, makes it virtually impossible for that person to transmit to someone else, what I referred to a few slides ago as U equals U. So theoretically, which would be essentially impossible, but theoretically, if you identified everybody who was infected and treated them, they wouldn't transmit to anybody else. On the other side of the coin, we know we now have pre-exposure prophylaxis that if you give one injection twice a year, you could have like a 99% efficacy in preventing the acquisition. So if we only implemented what we already have, we very likely can end the epidemic. And unfortunately, we're in a situation today with the atmosphere that we're in, that there are some roadblocks to that, to say the least. But let me close with this last slide, which my colleague Greg Focus and I wrote at the end of this last year in PLOS Medicine. And we refer to it, which is really the message of my lecture to you today, is that in the treatment and prevention of HIV/AIDS, it's really unfinished business. And taking a quote from our paper, after nearly 4 decades of progress with antiviral-based treatment and prevention for HIV, we now, today, have truly transformational tools to end the HIV/AIDS pandemic as a major global health threat. And I mean this when I say that history will judge us harshly if we squander this opportunity. Thank you.
Dr. Fauci, thank you ever so much. You should be justly proud of all that you've accomplished, really. We'll entertain a few questions. I'll open the floor now for questions.
Thank you for the great talk. I had a question about the 1980s. So in the 1980s, you were mentioning, my question is, how does a disease that was relegated or thought to be relegated just to the gay community become an issue of national concern? Because in the 1980s, until like even in the DSM, homosexuality is considered a disease at that time, and then it becomes a national issue. So how does that happen? Is it because the government looks at data and epidemiology that it is becoming like transmitting to heterosexuals, or was it because of the activism?
You know, that's actually a great question. It's a number of reasons why, because when you're dealing with a disease that more selectively affects a certain demographic group, it's still, we felt in the scientific community, and certainly it was promoted and made focused on by the AIDS activists, that we have a responsibility as a nation to not decide what demographic group is worth putting an effort into it if you have a disease that selectively affects them. So we pushed from my side and my colleagues, I certainly was not alone in this, that given the devastating nature of this disease in the gay community, we did a survey, a combined survey in the Castro district of San Francisco and in Greenwich Village. And to my truly shock, that the percentage of gay men in the mid to late 80s in the Castro district survey who were infected with HIV was over 40%. I mean, that is overwhelmingly devastating. So to me and to my colleagues, that is a national emergency in and of itself, even though it appeared to be and was relatively confined to a certain demographic group. So there was no question to us that it was a national emergency.
Thank you, Dr. Fauci. You know, in my career, I'm happy that I've looked after a few patients and helped them, but to see your career where you can claim to have helped millions is extraordinary. You've couched the recent changes, though, in terms of the American executive, but you're very famous throughout the world. Have you made approaches to, and has there been any response from the rest of the world, Canada and Europe as rich countries, and maybe Africa as emerging countries, to look after themselves?
That's a very good question that is at the center of the discussion of the PEPFAR program, because when we put the PEPFAR program together, it was not to have indefinite treatment and subsidization of the resources for HIV in these African countries. It was always planned to help them when they were essentially helpless, but making sure that they had a plan to gradually put in the resources to take care of themselves. And that's exactly what the plan was. And in certain countries, it's actually worked. For example, Botswana and Tanzania have very much essentially approached the point of being almost self-sufficient with their own resources. But the point you make is an excellent point. We can't be responsible indefinitely for taking care of the world, but we should feel, as President Bush said, somewhat of a responsibility as a rich country to help them to get started in taking care of themselves.
We'll take one more question.
Tony, it's John Dirks. I wanted to ask you, now that the research seems to be blunted in your country and global care is reduced, what glimmerings of hope do you have that new activism, new leadership, new public support will arise? Do you see it happening soon?
Well, I have to be perfectly honest with you, John. I don't see it happening soon, but I am hoping that it will happen soon, because we are having right now, unfortunately, a bit of an assault on science and public health. You don't need me to tell you that. All you need to do is follow in the media what is happening regarding vaccinations and other issues of public health importance. So I'd like to say I do see a glimmer of hope. But even though I don't see it, John, yeah, I know it's going to arise because I have faith in the energy and the good intentions and the passion of our young people in our fields of medicine and public health to know that we've got to do much better than what we're doing right now.
I'm going to have to cut off questions. And Dr. Fauci, thank you for leaving us with a glimmer of hope here. It's been a tradition to present on behalf of the American Osler Society the McGovern awardee with a medallion. Could you put up the photo of the medallion now? I don't know, Dr. Fauci, if you can see this or not. I hope you can.
Yeah, I can.
You can. Good. It's a medallion. We'll be sending it to you. You'll get it. With Dr. McGovern on one side, and on the back your name is engraved. So I think you'll have another keepsake.
Thank you so much, David. Thank you.
I want to thank you ever so much for a wonderful lecture.
Thank you. Thank you so much. I appreciate it.